This video discusses childhood sexual abuse and trauma in a clinical context. Please take care of yourself whilst watching. Millions of people carry the hidden weight of childhood sexual abuse into adulthood, and for many, finding the right therapy feels overwhelming. This video explores a form of therapy called EMDR, eye movement desensitization and reprocessing, and shares what a real clinical research study found when it was used with young adult survivors of childhood sexual abuse. The research was conducted by the founder of Sanctree as part of a doctorate in professional practice within the NHS Talking Therapies program. This isn't a theoretical overview. These are real cases, real outcomes, and real voices, and what they reveal has shaped the way we work with trauma at Sanctree. EMDR was developed by Dr. Francine Shapiro in 1989. It's an 8-phase structured therapy that uses bilateral stimulation, usually horizontal eye movements, to help the brain process and integrate traumatic memories. Think of it like this. Traumatic memories can become stuck, frozen in a distressing form that the brain keeps re-experiencing. EMDR helps the brain do what it naturally wants to do: process and file those memories in a way that reduces their emotional charge. It is now recommended by both the World Health Organization and the International Society for Traumatic Stress Studies as a leading treatment for PTSD. But what happens when it is used specifically with young adults who experienced sexual abuse as children? What do they say about the experience? That is exactly what this research set out to explore. This case series was conducted within the NHS Talking Therapies program. It involved 6 young adult women between 18 and 25, all of whom had experienced childhood sexual abuse before the age of 16. The research examined 2 things. First, measurable outcomes. Things like trauma symptoms, anxiety, depression, and self-esteem. And neuropsychological functioning, including attention, memory, and decision-making. Second, the lived experience of therapy. At 1-month follow-up, each participant was interviewed about what helped, what did not, and what they would recommend. It is worth noting that this research was conducted partly during the COVID-19 pandemic, which had a significant impact on therapy delivery. The findings were genuinely encouraging, but with important nuances. Participants who completed all 8 phases showed the strongest outcomes. They experienced significant reductions in trauma symptoms, improvements in self-esteem and quality of life, better sleep, and reduced anxiety. One striking finding: the subjective units of distress dropped from an average of 6.9 before treatment to just 1.9 afterwards. That is a clinically meaningful shift. Participants who only reached phases 1 or 2 showed some improvement, but less so. Real-world barriers often get in the way, and those barriers deserve clinical attention, not judgment. Completing the full protocol matters. The qualitative interviews revealed 3 major themes. The first was feeling safe, both in the relationship and the environment. Warmth, empathy, and genuine human connection were named as crucial to progress. One participant felt a symptom-focused approach helped. It helped her understand herself far better than a purely diagnostic approach. This shift prepared her for deeper trauma reprocessing. Time limitations were a concern. Several felt anxious about running out of sessions before completing treatment. Confidentiality concerns were raised, especially when sessions moved online, with worries about being overheard at home. Most participants found the shift to remote therapy difficult. The sense of connection felt harder to sustain online. Individual preference matters. This research carries clear implications. The therapeutic relationship is not simply a backdrop, it is a treatment variable in itself. Survivors may benefit from more flexible, individually tailored treatment pathways, rather than a fixed session cap. Preparation phases are just as important as processing. Building internal resources lays the foundation for deeper, lasting change. This is something Sanctree takes seriously. Treatment is shaped around the individual, not the other way around. This study addresses a gap in the research, specifically around young adult survivors, but it is a starting point, not a final answer. Future research will benefit from larger samples and post-treatment assessments conducted outside the shadow of a pandemic. The research confirms what clinicians have long known. EMDR works, relationships heal, and the environment is as important as the therapy. If you are considering EMDR therapy and would like to find out whether it might be right for you, we invite you to get in touch with the team at Sanctree. Our work is grounded in research, shaped by compassion, and always centered on you. Thank you for watching.